When you signed up for Medicare Advantage, someone probably told you it was a smart choice. Lower premiums, dental and vision benefits thrown in, a simple monthly cost that felt predictable and manageable on a fixed income. And for a lot of people, for a lot of years, that description held up pretty well. But here is what that same person almost certainly did not tell you, and what the insurance companies marketing these plans have very little incentive to volunteer. The moment your health changes in a serious way, the moment you face a major diagnosis, a surgery, an extended hospital stay, or a specialist you have been seeing for years suddenly falls out of your network, the financial reality of Medicare Advantage can look completely different from the picture you were sold when you signed up. And getting out is harder than getting in. Far harder, in ways that most retirees do not discover until they are already trying. My name is Finn, and this is Finn Retires, the channel built to make sure you have the full picture before these decisions lock in. If you are new here, hit that subscribe button right now. Every week on this channel, we cover the rules and the realities of retirement, healthcare, and finance that most people learn too late. And today's topic is one that is directly affecting millions of Medicare Advantage enrollees right now in 2026. Stay with me through this entire video because the information in the second half, specifically about the sequence you must follow if you ever want to switch back, could be the most financially important thing you watch this year. Subscribe and let us get into it. Let me start with a number that tells you exactly how significant this issue is. Medicare Advantage now covers approximately 55% of all Medicare beneficiaries in 2026. That is more than 35 million Americans enrolled in private managed care plans instead of original Medicare. And a meaningful portion of those people are having a very different experience in 2026 than they anticipated when they first enrolled. Prior authorization denials for medically necessary care, networks that no longer include the specialists they have been seeing for years, out-of-pocket costs in a serious illness year that bear no resemblance to the simple monthly premium they were told to expect. And when they try to leave, when they decide that Medicare Advantage is no longer working for them and they want to go back to original Medicare, they discover something that nobody clearly explained when they were signing up. Getting a Medigap supplemental policy to cover the gaps in original Medicare is not guaranteed. In fact, in 46 states, an insurance company can legally deny your Medigap application based entirely on your current health status. And by the time most retirees discover this, they already have the health conditions that are going to make that denial happen. I want to make something very clear before we go further, because this video is not designed to tell every retiree that Medicare Advantage is wrong for them. That would be inaccurate and unfair. Medicare Advantage works well for a significant number of people, particularly those in good health who use their plan primarily for routine and preventive care, who live in areas with strong plan networks, and who use the extra benefits like dental and vision regularly. The problem is not that Medicare Advantage is a bad product across the board. The problem is that the decision of whether Medicare Advantage is right for you is one that most people make at 65, when they are healthy, without fully understanding how that decision affects their options if their health changes at 70, 75, or beyond. And it is those downstream consequences, the ones that surface years after enrollment, that are driving the pattern we are seeing in 2026. Let us talk about why people are switching back, because the reasons are consistent and specific. The first and most commonly reported trigger is prior authorization denials. Prior authorization is a process that Medicare Advantage plans use to require pre-approval for certain medical services, procedures, specialist visits, and hospitalizations before they will agree to cover the cost. Original Medicare does not require prior authorization for most services. If your doctor says you need something and it is covered by Medicare, it is generally covered. Medicare Advantage plans operate differently. They have the right to require prior authorization for a broad range of services, and they have the right to deny that authorization if they determine the service does not meet their internal criteria for medical necessity. The result for many enrollees, particularly those dealing with serious or complex health conditions, is a cycle of denials, appeals, and delays that can feel like the insurance company is making their medical decisions for them rather than their doctor. According to 2025 federal data, Medicare Advantage plans denied a substantial portion of prior authorization requests, And while many of those denials were ultimately overturned on appeal, the process of appealing is time-consuming, stressful, and beyond the capacity of many elderly patients to navigate alone. In 2026, new federal rules went into effect, requiring faster decisions and more specific denial reasons. But the fundamental tension between insurance company cost management and patient medical needs remains. The second trigger is network disruption. Medicare Advantage plans use networks of contracted providers, doctors, specialists, hospitals, and facilities that have agreed to accept the plan's reimbursement rates. If your doctor is in the network, you pay the in-network cost sharing. If your doctor is out of network, you pay more, or in some HMO plans, nothing is covered at all. The critical issue is that networks change every year. A specialist you have been seeing for 10 years may not be in your plan's network next year. A hospital where you have had surgery may leave the network. A new plan provider may have a network that does not include a single physician in the practice where you have established care. And because these network changes are communicated through an annual notice of change that many enrollees do not read carefully or at all, the mismatch between who a retiree thinks is in their network and who actually is can surface at the worst possible moment, which is when they are sitting in an emergency room or trying to schedule a critical procedure. The third trigger, and this is the one that brings the financial reality home most sharply, is a serious illness or a hospitalization that reveals the true cost exposure of a Medicare Advantage plan. In 2026, the maximum out-of-pocket limit for Medicare Advantage plans has reached $9,250 for in-network costs under the federal maximum. The average plan's actual out-of-pocket maximum is somewhat lower, roughly $5,400, but that is still a significant and potentially catastrophic number for a retiree on a fixed income. For comparison, a Medigap Plan G policy under Original Medicare covers virtually all costs after the annual Part B deductible, which is $240 in 2026. The difference in financial exposure between a major illness on Medicare Advantage and a major illness on Original Medicare with a strong Medigap plan can easily be $4,000 to $5,000 in a single year. And for retirees who have multiple serious health events over several years, the cumulative difference can be far greater. Here is the moment I need you to pay very close attention, because this is the part of the Medicare Advantage conversation that is systematically underexplained when people are enrolling, and it is the part that causes the most damage when retirees try to switch back. When you turned 65 and first became eligible for Medicare, you had what is called a Medigap open enrollment period, a 6-month window during which any insurance company selling Medigap policies in your state was required to offer you any plan they sold, at whatever price they offered to healthy people, with no ability to deny you based on your health history. That 6-month window is a one-time, use-it-or-lose-it opportunity. Once it closes, the guaranteed issue protection it provided largely disappears. If you enrolled in Medicare Advantage during that initial window, instead of choosing Original Medicare and a Medigap plan, you did not use your guaranteed issue right. And in most states, outside of a limited set of specific qualifying circumstances, you will not get that level of protection again. This means that a retiree who is now 68 or 72 or 75 and who has developed health conditions since they enrolled in Medicare Advantage, conditions that are statistically very common as people age, like heart disease, diabetes, COPD, cancer, or kidney disease, may find that when they apply for a Medigap policy to accompany a switch back to Original Medicare, they are denied. Not because they have done anything wrong, not because they are not entitled to health care, simply because the Medigap insurer has assessed their health history and determined that covering them would cost the insurer more than the premium they would collect. In 46 states, this is completely legal. The insurer has no obligation to accept you, and without a Medigap policy, Original Medicare on its own has no out-of-pocket cap, meaning a retiree on Original Medicare without Medigap supplemental coverage is potentially exposed to unlimited cost sharing in a serious illness year. I want to give you a concrete illustration of how this plays out. Think about a retired accountant named Gerald, 71 years old, living in Florida. Gerald enrolled in Medicare Advantage at 65 because the plan had low premiums, covered his gym membership, and included dental benefits he valued. For 6 years, his healthcare needs were modest, routine checkups, a few prescriptions, an occasional specialist visit. The plan worked fine. Then Gerald had a cardiac event that required hospitalization, a catheterization procedure, and ongoing care from a cardiologist who was not in his plan's network. Gerald hit his plan's out-of-pocket maximum in that year. His cardiologist left the network the following year. He started experiencing prior authorization delays for medications his cardiologist had prescribed, and he began to understand, for the first time at 71, that he wanted to be on original Medicare, where he could see any doctor in the country who accepts Medicare, without prior authorization, without network restrictions. So Gerald tried to switch. He disenrolled from Medicare Advantage and applied for a Medigap Plan G policy. He was denied by 4 different insurance companies because of his cardiac history. Gerald is now on original Medicare with no supplemental coverage, exposed to potentially unlimited out-of-pocket costs in a year when his health is already requiring significant care. Gerald's situation is not unusual. Advocates at the Medicare Rights Center and KFF Health News have specifically flagged this pattern as one of the most significant and underreported consequences of the rapid growth of Medicare Advantage enrollment over the past decade. So, what options exist for someone who finds themselves in Gerald's situation, or who wants to avoid it? Let me walk through each one clearly. The first option, and the one with the strongest protections, is the 12-month trial right. If you are a first-time Medicare Advantage enrollee, you have 1 year from the date your coverage began to change your mind, switch back to original Medicare, and purchase any Medigap plan available in your state without medical underwriting. This trial right exists specifically to protect new enrollees who discover that Medicare Advantage is not the right fit for them within that first year. If you are within this window right now, if you enrolled in Medicare Advantage in the past 12 months and you are having doubts, this is the time to act. The trial right is time-limited, and it does not renew. Once 12 months have passed, it is gone. The second option is a Medicare Advantage open enrollment period. Every year from January 1st through March 31st, Medicare Advantage enrollees can switch from one Medicare Advantage plan to another or switch back to original Medicare. Coverage changes take effect on the first of the following month. However, and this is the critical limitation, this open enrollment window does not automatically come with guaranteed issue rights for Medigap. You can switch back to original Medicare during this period, but your ability to get a Medigap policy without underwriting depends on whether you qualify for one of the specific circumstances that triggers guaranteed issue protections. The third option applies to retirees whose Medicare Advantage plan is leaving the Medicare program or ending its coverage in their area, something that has become more common in 2026. If your plan is discontinued or exits your county or state, you have a special enrollment period that gives you both the right to switch back to original Medicare and the right to purchase a Medigap plan without medical underwriting. This guaranteed issue right is available 60 days before your coverage ends, or up to 63 days after it ends. If this situation applies to you, this window is critically valuable and should not be allowed to expire. The fourth option is state-specific and applies to retirees who live in one of the states with stronger Medigap protections. Connecticut, Massachusetts, Maine, and New York require insurers to sell Medigap policies year-round without medical underwriting, meaning any retiree in those states can apply for a Medigap policy at any time, regardless of their health history, and cannot be denied. Washington State and several others have what is called a birthday rule, an annual window where enrollees can switch Medigap plans without underwriting, providing some flexibility even outside the major guaranteed issue windows. If you live in one of these states, your options for switching back from Medicare Advantage are significantly more flexible than for retirees in the other 46 states. Now I want to address the sequence of steps for anyone who has decided they want to switch back, because getting the order wrong can leave you in a dangerous position. Step 1. Apply for Medigap first. Before you do anything else, before you call your Medicare Advantage plan, before you notify anyone that you are switching, apply for a Medigap policy and wait for a written approval with a confirmed effective date. If you disenroll from Medicare Advantage first, you are on original Medicare with no supplemental coverage from the moment your Advantage plan coverage ends, while your Medigap application is still being reviewed. If that application is then denied, You are left with original Medicare alone, and no path back to your Advantage plan until the next open enrollment period. The correct order is Medigap approval first, then disenrollment from Medicare Advantage. Step 2. Enroll in a standalone Part D prescription drug plan. Medicare Advantage plans almost always include prescription drug coverage as part of the package. Original Medicare on its own does not include drug coverage. When you leave Medicare Advantage, you will need to enroll in a standalone Part D plan to maintain creditable drug coverage and avoid the Part D late enrollment penalty we covered in a previous video on this channel. Make sure your new Part D plan is in place before your Advantage coverage ends, so there is no gap in drug coverage that could trigger a permanent penalty. Step 3. Confirm all dates and coverage transitions. Make sure your Medigap effective date and your Part D effective date align with the end of your Medicare Advantage coverage, so there is no period during which you are in any coverage gap. Keep copies of all written approvals, confirmation letters, and effective date notices. These documents are your evidence if any coverage dispute arises later. Let me also be honest about one more thing before we close out. If you are currently on Medicare Advantage, in good health, and satisfied with your coverage, this video is not a call to action to switch. It is a call to awareness. The right time to understand the Medigap underwriting issue is before it applies to you, while you are healthy enough to still have full options. Many retirees who switch to original Medicare and Medigap do so proactively, in their late 60s or early 70s, specifically because they want to secure their guaranteed Medigap access while it is available, rather than waiting until a health event makes it impossible. That proactive decision is not right for everyone. The premium difference between Medicare Advantage and a comprehensive Medigap plan can be significant, and that premium difference matters on a fixed income. But the decision should be made with full information, including the information about what happens to your options if your health changes and you want to switch back later. That is the information this video was built to provide. If this video helped you understand something about your Medicare situation that you did not know before today, or if it helped you understand a risk that was never explained to you when you enrolled, I want to ask you to share it. Send it to a parent, a sibling, a friend who is enrolled in Medicare Advantage, or who is about to turn 65 and choose their coverage for the first time. The decision someone makes at 65 about Medicare Advantage versus original Medicare has consequences that can follow them for the rest of their retirement. Giving them this information costs nothing. Not giving it to them could cost them far more than they realize. Drop a comment below and tell me, are you currently on Medicare Advantage, original Medicare, or are you approaching 65 and still deciding? What is the biggest factor in your thinking about Medicare coverage? The conversation in the comments on this channel is one of the most valuable things we have. Real retirees sharing real experiences, and your answer genuinely helps other people in this community make better decisions. I read every single comment personally, and your response matters here. The next video on this channel is going into the Medicare costs that retirees almost universally assume are covered, and are consistently surprised to discover are not. If you are not yet subscribed, hit that button now so you do not miss it. Take care of yourself, protect your healthcare coverage, and I will see you in the next one.